Hello, welcome to the Department of Psychiatry and Behavioral Sciences Grand Rounds. And my name is Joe Ceramelli, and I oversee Grand Rounds for our department. So I'll make a couple of comments just about the Grand Round series here. I'd really like to encourage you to write in any questions or comments during today's presentation into the chat or the Q&A. I can keep track of those. I'll collect the questions and I could go through those with presenters at the end. We're intending to have time available at the end for that. There is a group of us that works sort of weekly on the Grand Round series over the course of this academic year, which includes Samhar and Mike and Charles. And Charles has been working, we have piloted out a hybrid event last month. We're working through sort of how to address this going forward and what we might do about that. So we will certainly communicate about that in emails about Grand Rounds. There are a couple of different sources of funding, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and the Treatment of Mood Disorders Fund. And I think that's all for now about the Grand Round series, and I'll turn it over to Jürgen for an introduction of today's speakers.
Well, thank you, Joe. Hello, everybody. Welcome to our department Grand Rounds for today. So I'm going to start the introduction by saying happy birthday. We are celebrating the 10-year birthday of a great program in our department that you're going to learn about in this presentation. That's called the SMART Center. I'm going to tell you just a little bit about how I look at the SMART Center, and then you're going to learn a lot more from our presenters. So SMART stands for School Mental Health Assessment, Research, and Training. And for those of you who don't know the SMART Center, it's a really great group of faculty and staff that developed a partnership with the UW College of Education about 10 years ago, and have gone on to develop a really amazing portfolio of research and training focused on school-based mental health. They do their work at our department's offices at Sandpoint, but they're really working with schools and community-based partners all over the state. And I remember really pretty well the day when Aaron Lyon came to me to propose this idea of developing a center focused on school-based mental health. And it's just really neat for me to see all of the tremendous success that Aaron and his colleagues have had with this program in a relatively short 10 years. I knew at the time that the department had a great tradition of working with schools. That's work that Elizabeth McCauley and Ann Vanderstoep and others had started really decades ago. And so I felt like we had something to build on. And as many of you know, I'm always on the lookout for our faculty to help expand our impact and our research by partnering with people that have opportunities to work with individuals and families that are struggling with mental health and addictions problems that are not in our offices. So, we do work in primary care, we do work in schools, we do work in housing, we do work in criminal justice settings. And I think when it comes to kids and youth and young adults, well, they don't spend most of their days in a child psychiatrist or psychologist's offices. Hopefully, most of them are spending a good portion of their time in school. So there really are loads of great opportunities for mental health professionals to partner with teachers and others who are seeing and sometimes struggling with kids in school every day. So I was really enthusiastic about this concept, and I think I really only made one very small contribution to this program, and that is, and Aaron will correct me if I get this wrong, when he first brought me this idea, he brought me a really nice write-up, and on the top of it, it said, the DISH Center, D-I-S-H, I don't remember what it stood for. And I said, Aaron, this sounds like a really brilliant idea, but DISH isn't going to be something that sells very easily. It doesn't sound too exciting. So maybe do a little, do a little focus group and see if you can come up with a better name. And I think the next iteration was not just smart, it was brilliant. The next iteration was the SMART Center, and it really was very smart. So now, before I turn this over to Aaron and Jill, I just want to say a word about our speakers today. Aaron is a professor in our department. He's a psychologist. He has really deep expertise in youth and school-based mental health, in implementation science, in human-centered design of evidence-based practices. He founded and co-leads the Smart Center, and he also directs our department's NIMH-funded Alacrity Center. Jill Locke is an associate professor in the department who is also nationally, really internationally recognized for her expertise in this space, in particular on the care of youth who are on the autism spectrum and designing and testing evidence-based practices for youth with autism in school settings. I could say a lot more about both of them. They're amazing people, and we're really fortunate to have them as faculty colleagues. But with this, I think I will turn it over to Aaron to start our Grand Rounds presentation. Thanks to both of you.
Thanks so much, Jürgen. And if anyone happens to know what DISH stood for, you should put it in the chat. Maybe wrong answers only, and we can review them at the end of our presentation today. Let me share my screen. Hopefully everyone sees the sort of thing they expect to see in a place like this. So like Jürgen said, I'm Aaron Lyon, one of the co-directors of the Smart Center, and I'll be presenting with Jill. And we consider the Smart Center to largely be an implementation research and technical assistance center focused on implementing effective programming in schools for school-based mental health broadly defined. We tend to make use of what's known as the multi-tiered systems of support framework, or MTSS. That's really a school-based application of the public health model, which talks about the importance of primary, kind of universal prevention, selected interventions for some, and intensive interventions for a smaller few, although that smaller few is often more than the kind of pyramid we often show suggests. But we're so happy to be here as a component of our 10th anniversary celebrations. We have our 10th anniversary logo over my shoulder on our slide, and we're celebrating all year long. Our official birthday is tomorrow, December 2nd. That's when we receive name approval from the provost. Let's dig into it today. I want to begin with a land acknowledgement that the Smart Center acknowledges that we learn, live, and work on the ancestral lands of the Coast Salish people who walked here before us and those who still walk here. And we're grateful to aim to respectfully live and work on these lands with the Coast Salish and Native people who call this home. As an overview of what we're going to talk about today, I'm going to make some quick arguments that schools are an essential context for youth mental health service access and delivery, as Jürgen was already talking about. For the past 10 years, SMART's been dedicated to trying to ensure that students who are receiving services in schools are receiving the highest quality services possible and the most accessible services possible. We're going to be talking today primarily about SMART's research portfolio, which engages multiple system levels to achieve that objective. And I'm going to say the future's bright, and I'll tell you a little bit about that bright future at the end of our talk today. But I first want to start with sort of the problems that we're here to address. It shouldn't come as a surprise to any of you that the vast majority of youth who would benefit from mental health services don't receive them. This is due to so many different factors: number of trained clinicians, accessibility of appointments, insurance coverage, transportation to offices, often outpatient offices, insufficient time, structural barriers, including social stigma and medical racism, some of the distrust of organizational settings that provide services that can create among some of our most vulnerable or high need populations, and the low availability of the most effective treatments that can make the biggest difference in the lives of children and families. Schools play a major role in promoting the emotional wellness of our children and youth. Only about 20% of youth who require mental health services receive them. We have evidence to suggest that social emotional learning programs don't just impact the mental health well-being of students and families, but can even do things like improve academic achievement by 13% on average for our social emotional learning programs, often at the universal level of that MTSS structure I was talking about. Positive school climate itself can protect youth from external risk factors. And as we've already hinted, youth are more likely to receive mental health supports in schools than in any other setting. Depending on the research that you look at, anywhere between 50 and 80% of the mental health services received by youth happen in schools. And what's even more appealing to those of us at the Smart Center is that beyond this, school mental health tends to disproportionately positively impact the access to care for underserved youth, say ethnic and racial minority youth, who are that much more likely to receive school-based mental health services than in other types of settings. And despite all this potential, school-based services can be improved. The majority of attempts to implement school-based evidence-based supports tend to be unsuccessful. This is something we see echoed throughout all sorts of different service sectors and are well aware of within the implementation science field. 89%, for example, of nationally certified school psychologists report that they rarely or never use behavioral health evidence-based practices. And this is a term we've picked up from the director of the Institute of Education Sciences, which is one of our primary funders. They're the major research sponsor within the US Department of Education, that there's a persistent last mile problem in which education research of all types, including social, emotional, and behavioral research that we tend to focus on, fails to reach the individuals for whom it's intended. So this really caused us to think that we need to work hard and we need to work smarter in order to address this last mile problem. And most of our work does center around this last mile problem, conceptualized within an implementation science frame. So SMART's mission is to promote high quality, culturally responsive programs, practices, and policies to meet the full range of social, emotional, and behavioral needs of students in both general and special education contexts. SMART was our response to the service gaps that we saw in the literature and that we experienced firsthand in our work in schools and with districts. SMART focuses on research to conduct sort of basic fact-finding about school mental health needs and interventions, as well as develop and test new strategies for moving research into practice. We have a rapidly growing training, technical assistance, and evaluation core that really takes an implementation science approach to focus on training and TA. And you should all stay tuned for our March 2024 Seattle Children's Grand Rounds, which is going to focus primarily on this aspect of the Smart Center. And we've also increasingly had a pretty explicit focus on policy led by people like Eric Bruns within the Smart Center, where we try to be at the table with funders and policymakers, where we're often called on to provide information and expertise, all to promote positive legislation and its implementation as it relates to school-based mental health services and student well-being. As we got started, we had to figure out what to call ourselves in academia. And we really thought that Smart Center was the perfect intersection of the number of faculty and ego. So we went with that. And we've grown at what sometimes feels like an exponential rate over the last 10 years. Here you see just a subset of SMART faculty and staff. At last count, we totaled approximately 50 faculty and staff. That does include some part-time folks. But what began as a collaboration between UW Medicine and the College of Education has also recently grown to include the UW School of Social Work. And this union and these collaborations across these different schools and entities within the UW, I think really gives us a platform and the opportunity to have all sorts of impacts and roll out all sorts of supports for the different kinds of service providers that we tend to work with. I'm going to give you now a bit of an incomplete history of some major SMART milestones, where we've evolved over time from an applied research enterprise to one that tends to, as I was just noting a moment ago, almost as much technical assistance and practical support as it does research. And that's more of what the Grand Rounds is going to be focused on over at Children's in March. But first, I want to start with something that actually predates my arrival in Seattle or at the UW. Great things often have long unofficial histories. And there was a partnership with Public Health of Seattle and King County focused on the mental health services in King County's network of school-based health centers that was led by Elizabeth McCauley and partnered with TJ Cosgrove, who was at Public Health of Seattle and King County at the time, and was initiated back in 2005 with some support from the Robert Wood Johnson Foundation. And it was that sort of history that we were able to build on that I think Jürgen mentioned at the beginning of the hour. As we kind of came forward. And that was the context in which I was able to enter in, first as a postdoc and then as an early career faculty member, to be able to begin to build this explicit focus on school-based services. And again, before we even started the Smart Center, one of the things that first brought us together was a grant, as things often do in our academic world, that was a collaboration of some of us in the psychiatry department and the College of Education to develop a thing we called the Brief Intervention for School Clinicians. That grant was led by Elizabeth McCauley and Eric Bruns, and really gave us the first taste of an explicit and focused collaboration across these multiple entities, and started to show us what was possible. And so based on that, we moved forward pretty quickly and thought, we want to do more of this. So in 2013, December 2nd, 2013, we founded the Smart Center. And then we really got going. We received our first kind of official Smart Center, post-foundation or post-founding research grants, not counting some of the training grants that some of us had from the National Institute of Justice and Institute of Education Sciences. The IES grant at that time was actually called MENDER, led by Mike Pullman, and it was a collaboration grant, a research practice partnership award that we shared with Seattle Public Schools to address disproportionality in student discipline. In 2016, we received our first official SMART NIMH grant. That was a R21 to develop an implementation strategy we'll touch on later that we call BASIS, or Beliefs and Attitudes for Successful Implementation in Schools. Also in 2016, we launched our first large-scale technical assistance projects. These were in Skagit County and with the Marysville School District. And you can see after this point, across the remaining of the timeline as I walk through it, these sort of parallel and sort of two-pronged development of both our research enterprise and our direct technical assistance and support that we're providing as part of our Technical Assistance Corps to states and counties and districts and schools. In 2017, we received from IES a T32 style postdoctoral training grant that was led by Eric and allowed us to pull together some training resources and begin to really focus not just on the training of in-service practitioners, but opportunities to train the next generation of researchers focused on implementation and school mental health. In 2018, we really got a sort of jetpack for our Technical Assistance Corps when we were awarded the school-based supplement to our Northwest Mental Health Technology Transfer Center here in the psychiatry department. And that really allowed us to supercharge our technical assistance efforts and has continued to do so to this day under the leadership of people like Eric Bruns and Kelsey Schmitz. In 2020, we were awarded our 10th IES grant. This was actually a few different grants that we got all at once, maybe 10th, 11th, and 12th. And these were grants that allowed us to develop our HELM implementation strategy, Jill's ASD prep grant, and Tier 3 wraparound project that Eric had. Actually, in that year, we were awarded, it was a quarter to a third of all the IES social emotional grants handed out. In 2021, we were able to further expand our training and our research training enterprise when we were awarded a grant from IES for our Research Institute for Implementation Science and Education. And that's where we bring faculty from all over the country to the University of Washington, faculty who are doing work in different domains of education research, including those focused on mental health and social emotional well-being, to really beef up their implementation research skills. In 2022, we received our 10th NIMH grant. And another major milestone in 2023, led by Eric Bruns and Jen Stuber in the School of Social Work, we received a grant from the Department of Education to fund the Workforce for Student Wellbeing Initiative, to increase the school social work workforce, which, as I noted earlier, also helped to solidify our partnership with the School of Social Work so that SMART spans 3 colleges now. So what has all this resulted in? A current snapshot of SMART by the numbers. And I recently pulled all this information together, and it was even more than I thought. We have active projects currently in 720 different school districts, which translates into, and not that there are only 3,600 school buildings in those 720 districts, but that we've had recent touches and encounters and work in 3,600 school buildings. This all is made possible by $48 million in active research grants and contracts, primarily federal. And through all of this, we've found our way beyond simply the state of Washington, although we do plenty of work right here within the state of Washington and within Region 10 of the US, Alaska, Washington, Oregon, and Idaho, all over the nation to 20 different states where we have active projects, plus some in Canada. So we like to stay focused regionally, but we also like to think nationally and have pretty wonderful collaborations all over the country. Now, as we begin to move toward some of our specific projects, I want to talk a little bit more about implementation science, and the essential multi-level nature of implementation work. This is a figure of the CFR, the Consolidated Framework for Implementation Research, which we often use because we like how it provides us clarity for considering and understanding the multi-level barriers and facilitators of adoption and sustained use of innovative programs. So this includes things like the outer setting, broader norms, policies, and community influences. And in schools, this can include things like the academic calendar that we're often constrained to. We have 9 months to do everything, and then everyone forgets everything they were doing over the previous 9 months during the summer. This also has policy implications here and the intersection or sometimes conflict between different policies that govern school-based mental health. HIPAA, FERPA, which is HIPAA for education, and ways that some of the data that we're looking at often fall into one bucket or the other, or sometimes both. When services are implemented in schools that aren't academic, there can sometimes be this kind of policy misalignment. Sometimes our work can be facilitated by integrated data systems, though we don't have those as much as we would like. When I talk to some of my colleagues in Norway, they talk about these incredible integrated data systems within education that they make use of. And we are, as you might imagine, not always so lucky. Interorganizational linkages are important here because when you talk about school-based services, you also need to talk about referrals out. Even though schools are very accessible, sometimes there are especially high severity students who might be best served in another context. And those are the sorts of things that fall into the outer setting. The inner setting, the immediate organizational setting where implementation occurs, we often conceptualize this as particular school buildings, sometimes districts, but often buildings. And school leadership is critical to establishing implementation climate, and not just principals too. There's frequently distributed leadership teams within school buildings that we work with in order to kind of conceptualize leadership and implementation-oriented leadership as something that's really a team sport. But we often talk about both implementation climate, which can be sort of specific or strategic types of climate, as well as more molar or general climate that just affects how people feel in a place. Turnover rates are something that we deal with all the time, as many settings do, but turnover rates for educators are high, especially in a COVID or increasingly post-COVID era. Individuals also bring their own host of barriers and facilitators that we try to address and leverage as we can. In schools, when we're talking about school-based mental health, we're really talking about schools as the most common integrated service delivery setting for youth. where professionals from a lot of different backgrounds are providing care in a setting that wasn't necessarily designed for it. So we often have different backgrounds of service providers who may consider themselves clinicians, many who don't, and all manner of other types of people who can be supports, whether it's classroom teachers or paraprofessionals who can have a mental health impact on the students that we're there to serve. This includes other things like attitudes about evidence-based practices, and we have some strategies that are actually designed to try to improve attitudes right at that critical point before and after an initial training in a new innovative practice. And then intervention characteristics, which I think are often forgotten within the implementation science universe, but not all interventions are created equal. In schools, some are designed for schools, whereas others might be adapted to schools. And the adaptation process is one that needs to be done very deliberately and with a lot of input from local practitioners and students as well. There are plenty of non-evidence-based programs and practices at play in schools, and this has increasingly made us realize that we need to be talking also about de-adoption of lower value types of practices that may be out there. And I think with that, and focusing on this intervention level, I'm going to pass it over to Jill.
Thanks for that setup, Aaron. So I get the distinct pleasure of sharing some of SMART's past and current research portfolio. Think of it as speed dating of a slice of what we've done on the research end, as it spans the different domains that Aaron has laid out. So I'll start first with the interventions. Aaron, if you want to advance to the next slide, we're going to talk about BRISC. And so Aaron already talked a little bit about BRISC in terms of it being one of the first research grants that kind of laid the foundation for SMART. And this study was led by Elizabeth McCauley, Eric Bruns, Aaron, Janine Jones, Mike Pullman, and others. And it was one of the very first large federally funded grants that the SMART Center received. And the purpose of BRISC was to evaluate the efficacy of a 4-session engagement, assessment, triage, and brief intervention strategy for high school students that were seeking support for mental health services. And some of the results from the BRISC work suggest that BRISC is feasible to deliver, which is amazing to hear in schools. It's acceptable to students and very appropriate for the school context. And in particular, the process that BRISC outlines appears to be effective in enhancing student engagement in the intervention and identifying and addressing individualized student needs. Aaron, if you want to hit the next slide. These are all of my children and my dog, and I take a moment to take a picture before I help intervene. But our next intervention that the SMART Center has been a part of is in partnership with Karen Bears over at Seattle Children's and also in our department as well. And we adapted the Ruby parent training intervention for use in school settings, calling it Rubies, Ruby in educational settings. And what we're doing in that study, I think now we've had 3 grants on Rubies. We have adapted the original Ruby, made it appropriate for use in schools with educators, and now we're testing the same mechanisms of change. And so you can see kind of how we've done this process in terms of collaborating with our stakeholders, with building administrators, district administrators, teachers, general education teachers, special education teachers, paraeducators, specialists, you got it. So we ended up creating a new intervention that's on the right-hand side of the table. And that outlines all of the different components that might be used for schools. And so what was unique about Rubies is that we invited our school stakeholders to the table, and they actually sat down and helped us generate school-specific examples and helped us think through what could be appropriate or not appropriate, feasible, usable in schools. And so on the right is our new modules. And in the interest of time, I won't go through all of them. Our next intervention study is the Tier 3 wraparound study that's led by Eric Bruns and others. And so Aaron had mentioned that our framework that guides much of our work at the SMART Center is based on MTSS, or the multi-tier system of school supports, and positive behavioral interventions and supports. And it really focuses on addressing the social and emotional behavioral needs of students via different strategies across the tiers. We couldn't get through this presentation without showing you a triangle. But many of these interventions and strategies that SMART has developed are nested within this MTSS framework. And so this tier 3, not quite, Erin, this tier 3 wraparound study that's funded through IAS is unique in that it aims to build an intensive, evidence-informed, school-based care coordination strategy at that top tier for the students who have the most severe and complex behavioral health needs. So you can see from the triangle that the number of examples of strategies at tier 3 are fewer. And so the whole kind of purpose of the tier 3 wraparound study was to really understand how we can better provide those evidence-based supports and wrap around the students. So now you can go to the next slide. So I mentioned this is led by Eric Bruns, who is also our Associate Director of the SMART Center, but he also holds many hats, one of which is to direct the National Wraparound Initiative. And so that's a whole national team who are now completing this 3-year project to adapt this evidence-based community wraparound model for schools. And so the project has different aims to specify a practice model and school supports that are needed to make it happen for students that, again, have those most complex needs at the top tier 3 of that triangle. So this picture on this slide depicts sort of those details of what's important. So after a series of steps that involve engagement with the family, building a team consisting of their natural supports, school staff, and other important team members, the team supports those high-need youth and their families with resources that schools are otherwise challenged to provide. So specifically, an individualized plan is developed and implemented. There's follow-up and tracking of progress by a school-based care coordinator. And currently this project is underway, and it's demonstrated so far that this kind of wraparound process can be done in schools with a great benefit to students who, again, otherwise might not be getting the care that they need to be successful in school. And then hot off the presses is the usability project funded by IAS. This is led by Erin and Eric, and it digs into what makes certain programs more or less implementable in community contexts such as schools. And it's based on the idea that intervention usability, or the extent to which these interventions can be used by different users or specified users to achieve specific goals around effectiveness, efficiency, and satisfaction, is a key sort of upstream determinant of both implementation outcomes, such as appropriateness or fidelity, and the service outcomes that are the purpose and goal of any implementation project. So we're really trying to improve those implementation outcomes to ultimately get to those student outcomes. So this project is going to use methods that are adapted from the human-centered design field to evaluate the usability of 10 leading evidence-based prevention programs to promote social, emotional, and behavioral well-being. Again, think about pyramid. So information about intervention usability will be linked to the extent to which intervention implementation has been successful in real-world schools to determine which facets of usability are most important to uptake. So that kind of wraps our kind of basic portfolio of interventions, although I think we're missing a few. Sorry, Erin, I think you should have fast-forwarded one more. I think we're off a little bit. Okay, so moving on to sort of the individual level, based on the CFR model of what we're looking at from the provider's perspective, the first suite of studies is BASIS, and that's the Beliefs and Attitudes for Successful Implementation in Schools, or BASIS program, that's been active for a very long time at the SMART Center, I think almost as long as the SMART Center has been in existence. So Erin, Mike, and colleagues have gotten 5 federal grants to develop and test BASIS, which is based on 2 major theories that are often used in the implementation science world. So one being the theory of planned behavior, which states that attitudes, norms, social norms, and self-efficacy are the largest drivers of intentions, which in turn drive behavior, and the health action process approach. So BASIS is a brief and pragmatic strategy. It bookends initial training at the school and is designed to increase engagement from the practitioners or providers and investment during and after the training period. So there are 2 kind of flavors, as Erin describes them, of BASIS that have been developed in parallel across those 5 different projects. One focuses on school-based clinicians who are implementing intensive interventions such as trauma-focused cognitive behavioral therapy, and one focused on teachers who are implementing more universal prevention programs at the tier 1 of that pyramid that we showed you. So the findings to date from some of the studies that I have wrapped have supported the impact of BASIS on provider engagement, so educator engagement, clinician engagement, and implementation outcomes across a variety of interventions. And most consistently, BASIS has been found to impact the likelihood and speed with which providers have adopted new interventions, especially early in that implementation process. And in one of the randomized trials, the findings indicated that BASIS greatly increased the time school-based clinicians remained in that post-training consultation for CBITS, the trauma-informed intervention. So interestingly, in that figure that is on the bottom right, you can see that clinicians ultimately ended up in the same place, providing specific support for BASIS as an adoption-focused pre-implementation strategy, so before implementation actually happens, that helps to support providers or educators through the critical post-training period. And in our next study, led by Frida Liu, Aaron, and others, is called Vibrant. And you can see that Vibrant stands for the virtual implicit bias reduction and neutralization training. Kudos to that name team for school mental health clinicians. And Vibrant, again, is intended to be a brief, about 45 minutes or so, interactive, self-paced online training designed to help school-based mental health clinicians manage their implicit or racial biases in clinical encounters. And so Frida and team conceptualized Vibrant as an equity explicit implementation strategy that could conceivably be paired with any EBP. So ideally, it's EBP agnostic to promote equitable implementation. And they currently have a hybrid type 3 implementation effectiveness pilot feasibility trial where they're testing Vibrant with measurement-based care or the systematic collection of patient-reported data to inform clinical decision-making. And so Vibrant's expected mechanisms of action would look something like this. So if you hit the first button, Aaron, Vibrant would reduce the impact of implicit prejudice and stereotyping, which is expected to improve equitable implementation. And keep going. How much measurement-based care they are doing with minoritized versus mainstream youth on their caseload, and therapeutic alliance leading to improved mental health outcomes for minoritized youth. And so Vibrant is currently in active recruitment. They're aiming for 80 school-based mental health clinicians, and they're about a third of the way there, which is very exciting. The next study, also again at that provider level, is iBest. And that is led by Carol Davis and Mike Pullman and others from the College of Education. And iBest is the integrating behavioral support and team technology coaching collaboration tool. So again, this is for students who are have very chronic challenging behaviors. And so the purpose of this study is to test the efficacy of this new technology or this new tool, the iBest tool, that's intended to design to improve the use and effectiveness of those tier 3, again, the top of that pyramid, function-based behavioral supports for students that have really chronic, challenging behaviors that might interfere with their day-to-day activities and functioning. So in the last 2 decades, there's been an increased focus on that systems-wide positive behavioral interventions and supports approach to help student learning. But educators often struggle to provide the appropriate intervention options for students that have those complex needs. And so barriers to implementing those tier 3 interventions within that MTSS or the multi-tiered system of supports framework include time to communicate and collaborate, beliefs about how children learn, and their lack of behavioral expertise. And so this iBest tool, if you go back one slide, Aaron, was developed to remediate those barriers, to guide those intervention teams through their process of providing supports. And so this study, also funded by IES, will evaluate the efficacy of iBest for improving those behavior and educational outcomes of elementary school students that have challenging behavior. All right, so moving on to the next part of the CFR around the organizational level. Thanks for that image, Aaron. Is our helping educational leaders mobilize evidence, or a HELM implementation strategy. And this was a redesigned study also funded by IES from the Leadership for Organizational Change for Implementation Intervention, or the LOCI implementation strategy, from Greg Ahrens and Mark Earhart and others. And so in this study that Erin and I led, we had a series of iterative developmental phases to redesign Helm. And so we did some stakeholder focus groups to figure out what aspects of LOSI should be changed or are not feasible or could be translated to the schools. We held an expert summit with a hackathon as well to gather more information from folks that are in practice as well as in research in this space. And then we did a series of demonstration feasibility trials, tinkered with Helm, created Helm, and then we piloted it last year. And so that study is in analysis now. If you go to the next, thanks, Erin. So Helm kind of comprises these components. So there's an assessment piece where we really take 360-degree data on all folks at the school. So we tested this in elementary schools, so the principals as well as the teachers and teams and paraeducators. There's a didactic component where we provide training in some of those strategic concepts that Erin mentioned earlier in terms of implementation leadership and implementation climate. So how do we foster a strong implementation climate for evidence-based practice use in the schools? Helm's also designed to be EVP agnostic, similar to Vibrant. We have a leadership development planning session as well, where we take the data from the schools, feed it back to the schools. They come up with these implementation plans to foster their leadership or implementation-specific leadership. And then we provide that individual and group coaching to support that leaders or the principals, administrators, execution of their plan. We provide some organizational strategy development at the district level to support the buildings that are using Helm. We have these professional learning collaboratives where principals that are being trained together can come together and discuss things that are going to be relevant to their implementation. And then we have graduation, which is a big fun party. So that's one of our organizational strategies. And if you go to the next slide, I'm part of our Autism Intervention Research Network on Behavioral Health. It's co-led by Connie Cassidy, David Mendel, Alvin Samer, Elizabeth Hazrick, Brian Boyd, Susanna Idarola, and me. So it's across now, I think, 8 universities because Brian spans UNC and Kansas now. So if you go to the next slide, Erin, what we're trying to do in AIRB is test a novel implementation strategy at the organizational level called United. So it's using novel implementation tools for evidence-based intervention delivery. It combines organizational psychology with social network theory to figure out who should be on implementation teams and what we should do as a team in the organization to better plan for implementation of these various evidence-based practices for autistic youth. Go to the next slide, Erin. So what's special about AIRB, you can just click it 3 times, is that we are simultaneously testing United across birth through secondary school. So there's 3 different evidence-based practices, one in the early intervention system, which is Mind the Gap, which is for, again, the early intervention system. So it's a parent navigating tool to help families go through the process once they've gotten a diagnosis. And then in elementary school, we're testing Remaking Recess, which is a social engagement intervention that's designed to support educators in supporting their social outcomes of autistic youth. And then in middle and high schools, we're testing United in the context of the self-determined learning model of instruction. So focused a lot on self-determination skills, which is a pivotal skill to unlock some of those post-secondary outcomes for autistic youth. So again, spanning birth to age 22 and testing the same implementation strategy across these 3 different contexts, 3 different interventions, 3 different populations, if you will, based on age. So that study is still underway right now, which is really cool because we're also in schools in Canada as well. Next slide, Erin. And so Erin already mentioned Mender, which is our minority engagement and disparity reduction study, which was led by Mike Pullman, Janine Jones, and others, and was in partnership with the Seattle Public Schools. And the purpose of Mender was to form this partnership with Seattle Public Schools to build capacity and assess and address disproportionality in school discipline practices. So as you can see on the slide, students of color are 5 times more likely to receive punitive school disciplines than white students. And so these disciplinary practices are often associated with disengagement from school, lower academic achievement, truancy, and dropout, so things we don't want. And Seattle Public Schools wanted to learn, how do we use data to develop and test these collaborative intervention approach? So use really this data-driven approach to figure out what strategies to use. So that resulted in the development of the disproportionality and discipline assessment for schools, or the DDAS measure, and a pilot test of the engage, maintain, restore relationship building strategy, which I believe also had a follow-up IES study, which I didn't talk about today because we're also running out of time. So now I'm going to pivot, which is not part of our C4 diagram at all, but I'm going to pivot to our training grants. And Erin alluded to some of these already, but we were very fortunate to receive a Smart Prep grant from IES, again, led by Eric. And the focus of Smart Prep was to prepare education researchers to conduct relevant, high-quality research focused on the social and behavioral concerns for academic learning and the use of mental health strategies in educational practice to improve student outcomes. And the fellowship allowed us to train 4 individuals. So we have these lovely 4 fellows listed here. They were each trained for 2 years. And each fellow was paired with a senior mentor who worked closely with a fellow on existing funded projects that included development, evaluation, measurement projects, but also helping them develop the communication and other skills necessary for educational research. So all 4 now are in faculty positions. We're very proud of them. Maria Hugh at the very bottom is at the University of Kansas. Courtney Zoloff McCurdy is here at the University of Washington. Larissa Gaius is at the University of Massachusetts Lowell, and Kathy Corbin is at the University of Florida. So we have successfully moved them on to faculty appointments. Again, we're very, very proud of them. We still work very closely together, which has been a very nice, I think, extension of the Smart Center. And our next training program, led by Erin, Eric, and others at the Smart Center, is RISE, which is our Research Institute for Implementation Science and Education. So it's a training program for established educational scholars across domains. So folks study literacy, social emotional learning, STEM, autism, school leadership, etc. They're interested in expanding their portfolio around implementation science. So the training program leverages much of what SMART is really good at. So those practical and meaningful implementation and applied research to help expand implementation research workforce in education. So it's a 2-year experience, and so established faculty from other institutions receive mentorship from the core RISE faculty from the UW, the University of Virginia, the University of Oregon, the University of Michigan, Florida State, and the University of Connecticut. And so what you see here is a map of the primary RISE components, including the annual week-long summer institute that's held in Seattle, the ongoing mentorship, and the webinars. And you can see one fellow has stated, and this was not planned or plugged, that there is truly nothing like RISE for education researchers who are also implementation scientists. This training program fills such a critical gap for the future of U.S. school systems and students, which is really exciting to hear. So far, we've had 2 RISE cohorts. You can see them all here. Although building expertise is just one part of the RISE model, building connections and collaborations is just as important. So we envision connections within cohorts, but we also envision connections between cohorts as we ensure that the cohorts overlap to help build an implementation research community in education. And they're collecting social network data to evaluate the extent to which this is happening. So that's very exciting. So stay tuned for all of that.
Thanks so much, Jill. And now I think I get to bring us home with a discussion of what the future holds for SMART. And we all know that nothing says the future is here like a flying car from 1989. So future directions. There's just a few of them here that I'm going to go through. One of them is continued integration between our research and technical assistance arms. Moving some of our tested implementation strategies that Jill was talking about, like BASIS and Helm and others, into implementation practice and being able to expand their reach that much more via our technical assistance and consultation core and other outlets such as that. And just to plug it one more time, we will have a Grand Rounds that's focused more on our technical assistance efforts in March at Seattle Children's. Continued workforce development. both to develop our research workforce, as Joe was just talking about with our postdoctoral fellows and things like RISE, and our practice workforce, like the WSW initiative in partnership with the School of Social Work. Expansion of SMART's implementation research portfolio. We're certainly not ready to stop or anything like that. We've been taking a lot of our strategies from development and sort of iterative testing phases into larger scale trials. Jill and I are hoping to, before too long, get funding for a large scale trial of the Helm strategy. So it can follow in the footsteps of some of our other strategies that have already kind of made it to that stage. One thing that harkens back to part of what Jürgen was saying at the beginning, my other major hat is to co-direct the UW Alacrity Center. And I think you can see a lot of the human-centered design types of methods that the UW Alacrity Center is really pushing forward in a lot of our work. That Jill was talking about, whether it's very explicit like the usability study, or whether it's using some of our implementation strategy usability assessment methods in things like the Helm project, which we've been able to do. We were recently renewed at the UW Alacrity Center for another 5 years, and 3 of the 4 signature projects for the P50 Alacrity Center are led by SMART Center faculty and are focusing explicitly on school mental health and the redesign of interventions or implementation strategies to ensure that they can be appropriate to that context. So we anticipate much more cross-pollination and opportunities to raise all ships. And then finally, continued Washington State and regional advocacy, but we do have, for obvious reasons, a particular investment and focus on Washington State, and have such deep and rich partnerships across the state that's much of what we'll be profiling with our next celebratory Grand Rounds in March. So to wrap up the way I started, schools are an essential context for youth mental health service access and delivery. The SMART Center has been busy over the past 10 years, and we're not done yet, but we've really focused on ensuring that the social, emotional, and behavioral supports students receive in the education sector are high quality, regardless of its universal prevention or indicated interventions for significant clinical problems. SMART's research portfolio explicitly engages multiple system levels to support implementation. We often isolate particular system levels in order to evaluate the effects of particular strategies on, say, individual level sort of mechanisms, things driven by like the theory of planned behavior, or the organizational level, and think about implementation climate as we do in Helm. But we also recognize that implementation is always a multi-level endeavor in the real world. And we really look for that kind of synergy between what we can learn focusing on one level explicitly in a research project and what its implications can be contextualized fully within multi-level implementation barriers and facilitators. And I think the future is bright. And so do all these people. And we would love some questions in the remaining time. Thank you.
Well, very good. Thank you, Jill and Aaron, for walking us through the history and range of current work, ideas about the future and next steps in the SMART Center. There are several questions that have come in. We do have a couple of minutes left. I encourage people to write in with more questions, comments as they'd like. Some questions were kind of broad, reflective type, some maybe more narrow. Maybe starting with a broad one. This is interesting, I think. What do you think? I mean, here clearly a lot of research, a lot of outcomes, a lot to think through, but what's one of the biggest findings that you think you've been either surprised by or that's been impactful in some way that you've seen over the last 10 years?
I mean, I think one thing, maybe it's because I'm a pessimist at heart. I'm always surprised when things work. But we've had a number of studies for our BASIS strategy that have demonstrated its impact on sort of immediate adoption and some of those initial adoption behaviors that teachers or school-based clinicians are going to have. And we've continued to see that, including in some preliminary evaluations of our BASIS R01. So I'm pretty excited about this sort of that program of research that just comes to mind readily, and its opportunity, especially because BASIS is such a pragmatic implementation strategy that we're trying to make more pragmatic all the time and lower resource in order to have the greatest reach possible.
Great, thank you.
Jill, you have anything to add?
Well,
And-
I was gonna just respond to like the future directions of where I hope we go. And I know we alluded to a little bit about this, where there's that huge implementation cliff when summer happens, when schools switch periods, grades, etc., kids switch schools. I think we have a lot of work to do in that space to really figure out how do we maintain those supports, maintain those educators' delivery of evidence-based practices the next school year and beyond with a different cohort of students. I think that's where I think part of what we've learned should go.
There were a couple of specific, sort of maybe more study-specific questions. And one maybe bringing up just kind of, for lack of a better term, lower intensity skills. Someone brought up the example of a recent study I'm not particularly familiar with, but about DBT skills adaptation for adolescents without psychiatric disorders, and that seemed to have perhaps adverse effects. Maybe you're aware of that. And I think the question is more of, is that a risk? Is that something that's come up in any of your work or that you've observed? And the question was specifically about universal. Yeah.
I do think there's been some, including some popular press coverage of some of that lately. And I think that's why it's important for us always, regardless of whether we're evaluating interventions or our implementation strategies, to be on the lookout for unintended consequences that might be happening and to really get into the nuance of it. Like the particular article that highlighted that recently was a relatively brief piece, and I think wasn't able to get into all the nuance of different universal programming. But sometimes we do have evidence that universal programming or any kind of programming may be best suited for particular kinds of problems and maybe not others. And as we innovate, we need to be able to consider that we might be having unintended consequences. There was actually a great paper that our colleague Mike Pullman pulled together on ripple effects or unintended consequences of implementation of youth mental health, and trying to catalog sort of different potential types of unintended consequences or secondary outcomes. And I think that's some of the most exciting work we can do, recognizing that we don't have all the answers. Sometimes we're going to misstep. Sometimes, and I'm not saying that DBT prevention program, sort of built prevention programs are missteps, but that evaluating, what we're doing and how we're doing it is always important. And recognizing that there are plenty of programs out there that schools are using that have no evidence whatsoever. And that they may also be ripe for evaluation of positive or iatrogenic effects.
Thank you. Jill, would you like to comment or maybe take a different question? There's
Yeah, I'll take a different question.
okay. There's one that's maybe getting really specific, really down into individual outcomes. Has that been a focus? Is even monitoring or assessing individual student outcomes, has that been part of sort of a project to implement? And it may have been something you mentioned. And I guess how different is that from what's usually happening in schools? Maybe you could comment on individual outcomes.
Yeah, so I think that's always our end goal. And I think a lot of those implementation studies want us to include a lot of the student outcomes. It's often hard to do altogether because we're trying to connect whether better implementation leads to better student outcomes. So I think with some of the other studies, I think BRISC, the Ruby study, that have intervention focuses, the primary outcome has been student level. So we do have some of that for social, emotional, behavioral data, behavioral health data. We also partner a lot with the schools to get academic level data that the schools provide to us to see if, anything that we're doing at the intervention level or implementation level is affecting that as well. But that is something that's quite important to the center and to our work.
And with specific regard just to some of our study designs, we're frequently doing what are known as hybrid effectiveness implementation trials. that to one extent or another are focusing either on implementation effects or on the effectiveness of interventions that already have a certain amount of evidence behind them. But within those types of study designs, we are frequently, if not usually, evaluating student outcomes along with our implementation outcomes, even if the experimental manipulation is actually novel implementation strategy versus implementation as usual.
Well, very good. I appreciate the range of questions that you took here, from sort of larger perspectives down to sort of maybe more specific, or even focusing on individual outcomes here. And here we are just at the end of the hour. And I think, how interesting to hear about this. I was especially interested in the training domain. That's really exciting to think about, training other individuals in developing research skills in this focus an area, among all the other work that you've done as well. So thank you for presenting in the Grand Rounds series today. And I think you had mentioned there's a Seattle Children's Grand Rounds coming in March. So I encourage others to join that, to listen to other details of the work that Aaron, Jill, and others have done in the Smart Center.
Thank you so much. Wonderful to be here.
Thank you all so much for having
Thank
us.
you. Thank you. Take care.